we start, sir?
I think the team is here whenever you wish to, Mandar. Immediately
Yeah,
we
it
can.
is sharp 7:31, so I think we can start.
We can start, surely.
Sure, sir.
Chetan, are you going to put the first slide?
Yes, sir. Just wait. First, I make you live. Then I will share the screen.
Chetan, can I start?
Just wait, sir. Yes, sir. You can start.
Yeah, good evening, everybody. On behalf of Alkem, the fifth largest pharmaceutical company in India, I welcome all our esteemed panelists as well as our moderator, Dr. Chadda, Dr. Manoj Chadda, for this evening discussion, DPP-4 inhibitors in the present era. I would introduce our moderator as well as panelists to the audience very briefly. We are very fortunate to have a galaxy of panelists today for our discussion on DPP-4 inhibitors in the present era. I would introduce Dr. Chadda to the audience. Dr. Manoj Chadda actually does not need any introduction. The DM endocrinologist from very prestigious KEM Hospital and GS Medical College from the 1987 batch. In fact, he's the second DM endo in the entire Mumbai. He's attached to Hinduja Hospital, Mumbai. He has got his own setup, Hope and Care Center at Vashi. In fact, he was formerly the faculty at the Department of Endocrinology at KEM and Nair, and Associate Professor of Medicine at MGM Medical College, Navi. He has more than 10 years of teaching experience in endocrinology at KEM and Nair, and he's in use of artificial pancreas. He's the immediate past president of Endocrine Society of India. He's a fellow of Royal College of Physicians of Ireland. He's a fellow of Indian College of Physicians. He is the examiner at Part 2 membership exam for Royal College of Physicians Ireland. He's a member of National Academy of Sciences, and he has been at the faculty at ESICON and RSSDI meetings for more than 20 years now. So I welcome sir to you for this meeting, and thank you very much for having accepted our invitation as a moderator for today's discussion. Chetan, Dr. Dhiren Shah's resume. Sir, thank you very much for accepting our invitation as a panelist today. Dr. Dhiren Shah is a very senior cardiologist practicing for 35 years in South Mumbai. He has a comprehensive setup of cardiology, echo, stress test, Holter, ambulatory blood pressure monitoring, as well as PFT. He's a consultant cardiologist at Reliance, HN Hospital, Saifi Hospital, Jaslok Hospital, and Bhatia Hospital. He's working in invasive cardiology department with excellent exposure to coronary angioplasty. Our second panelist for the day is Dr. Tejal Lathia. Dr. Tejal Lathia, once again, is a DM in endocrinology with the gold medal at TNMC and Nair Hospital. She is a consultant at Apollo and Fortis, Navi Mumbai. She has numerous publications and posters, particularly at ACE 20 and IDF 19. Some of the posters like telethyroidology in thyroid research and which has appeared in thyroid research and practice, which are the currently accepted publications like gender diabetes in diabetes and obesity, interrelationship of menopause and diabetes, which has appeared in diabetes research, anti-cancer drugs and sodium hemostasis, which has appeared in European endocrinology. And of course, she has written chapters in bariatric surgery, Urja, clinical pearls in diabetes, as well as in landmark clinical trials. Our third panelist for the day is Dr. Sukirti Mishra. Dr. Sukirti Mishra is a very young DM Endo from Topiwala National Medical College and Nair Hospital. She is the assistant professor in endocrinology at Topiwala National Medical College and Nair Hospital since October 2020. And she was very, very humble enough not to put her achievements, and she told me not to put her achievements in the CV. So that's it, Dr. Sukirti Mishra. So I hand over the session to Dr. Chadda for the further proceedings. Thank you very much, everybody.
Okay, so thank you, Mandar. And in the beginning only, let me thank Dr. Dhiren Shah, Tejal and Sukriti for being part of this panel discussion. See, what we plan to do in the next, say, 45 minutes or so is discuss some common issues in practice. Maybe the focus is on DPP-4 inhibitors, but a little here and there also, if you go, it's pretty acceptable. I will direct my question to one of the faculty, but that doesn't mean the other two cannot put in their comments. My only request is, since we have 45 minutes and we need to cover quite a bit of distance, let's keep the answers short and cryptic. If something is still required, maybe I will needle you for that. So I think in today's scenario, we keep hearing so much about SGLT2 inhibitors and GLP-1 receptor analogs. So the question always comes as is whether we still have a place of DPP-4 in our inhibitors in our practice. And while we were getting ready, I just had this thought, 2005-06 was a time when DPP-4 inhibitors actually came onto the scene. And we had our first advisory board meeting in India, in Mumbai in 2008 for the introduction of DPP-4 inhibitors. And to be precise, it was on sitagliptin. So historically, probably Tejal and Sukriti would not remember, but just to refresh their mind, these inhibitors were available for a price of $6 a tablet. And in those days, a dollar was about 42 rupees. So when we saw the data and we had this meeting first time, 42 into 6 is about 250 rupees for a tablet of a DPP-4 inhibitor, which at that time looked like a glorified metformin. A1C reduction of 0.8, 0.9%, very good, very safe, but nothing greater than metformin. So fortunately for us, at that time, two of the big bosses in Southeast Asia were Indians, and two colleagues, I won't name them, but they were in Singapore. And they talked to the white bosses in the US that if you want to get DPP-4 inhibitor into India, then its price has to be India specific and not world specific. And surprisingly, they agreed. And sitagliptin, Januvia, was introduced in the Indian market at 42 rupees a tablet, which is the equivalent of $1 in those days. Now, historically, rest everything you all know what happened, how the other DPP-4 inhibitors came in, vildagliptin, saxagliptin, linagliptin, and then the price war went on. But we are not here to discuss economics. We are here to discuss science. So let me start by asking Sukriti. She can be the opening batsman. She's the youngest of the lot. The ADA ESD guidelines, which keep coming up every year with little modifications, how do they place the DPP-4 inhibitors in our practice? And if briefly you want to comment on the combination therapies with DPP-4 inhibitors, and then I will go to Tejal and Dr. Dhiren Shah.
Right, sir. Thank you. Sir, actually, the recent ADA 2021 has classified the diabetics into based on the comorbidities they are associated with. So people with the ASCVD risk factors or with CKD have been advised SGLT2 inhibitors and GLP-1 analogs. And after metformin, still persists to be the first line drug along with the lifestyle modification. And after that, as a third choice comes DPP-4 inhibitors in such scenarios. But DPP-4 inhibitors have been placed as a second choice in people who have multiple comorbidities, in which our prime motive is to avoid hypoglycemia rather than having a very strict glycemic control. So this is right now the current ADA stand. And as per combination therapies, sir, usually with metformin, we have seen the combination therapy. So a recent study showed that metformin itself induces GLP-1 production. So if that is the case, they form a wonderful combination because they have different mechanisms of complementary actions. Metformin basically increases the insulin sensitivity, and these usually maintain the beta cell mass and help in increased secretion of insulin with the help of potentiation of GLP-1 activity. So along with other like insulin, there was a study, Asian study conducted, which mainly comprised of Chinese subjects. It showed that combination of insulin with the vildagliptin rather than just placebo decreased the episode of hypoglycemia. This was quite revealing because initially we thought that the main mechanism is just through GLP-1 potentiation, but it also enhances GIP production. There's resistance in type 2 diabetics over a long period of time, but as the glycemic control improves, this GIP action comes into play and it acts as a counter-regulatory mechanism to prevent hypoglycemia. And recently there was talk about SGLT2 inhibitor with GLP-1 analogs, and they have complementary action. But surprisingly, it was found that the combination does not work that well as it was expected. So probably the endogenous glucagon production, which is stimulated by glucosuria of SGLT2 inhibitors, is not overcome by the DPP-4 inhibitors to the extent we expected.
Okay. So, Dr. Dhiren Shah, you would like to sort of take this as a cardiologist looking at combination therapy, and then your remarks as regarding the Verify trial.
Yeah, so I think after Verify trial, it was fairly clear that step care therapy, what always used to be with hypertension, with diabetes, initial metformin, on follow-up step increase, keep on your sulfonylurea maybe, or DPP-4 inhibitor. So the first time, like in diabetic, like in hypertension, we have two drugs started initially. Similarly here, the combination of metformin DPP-4 inhibitor works out much better. And in this Verify trial, it was very clearly shown that when you start both drugs together, the metformin as well as DPP-4 together, it will have much better control of diabetes, much earlier, smoother control, and over a period of 4 to 5 years, whatever the follow-up period there, it was 2 years. But over a period, even the event rates are reduced. So it's always better to have good anti-hyperglycemic two-agent combination. Metformin, which is having a GLP-1 effect to some extent, plus peripheral sensitization, and at a pancreas level secreting insulin. So, and DPP-4 inhibition of all octet sites, majority are covered. 4 are covered by DPP-4 at GI level, at liver, at the pancreas level. So this combination works out theoretically very, very, very well. And SGLT2 has little theoretical limitation that below certain GFR, since it is working through kidney, it may not be as effective. So in such situation, DPP-4 in this scenario will work better. Here the metformin also gets into a trouble below eGFR of 30. So here DPP-4 comes out at a lower dose, quite safe, where even the other drug cannot be opted upon. So ideally, all these 21 guidelines recommend ASCVD and diabetes, drug of choice, metformin, followed by SGLT2, definitely. But we are left out with select group of those patients where we may not expect a good benefit with SGLT2 because of higher creatinine, and probably metformin also may not be so effective. on top to avoid hypoglycemia. This is one of a good drug to combine in elderly. So this may makes it a suitable combination in elderly also.
Thank you. So Tejal, coming to you, I mean, you've been practicing for a long time now, and in the last 3-4 years, you've seen the fixed dose combinations of DPP-4 inhibitors with SGLT2 inhibitors. Broadly speaking, I'm not speaking of a specific DPP-4 inhibitor. What has your take been on the choice of when to start? I think Dr. Dhiren Shah made a point about step care versus multiple drugs at the same time, and we have read so much about the metabolic memory and the legacy effect. So what would your take be in terms of starting in a drug-naive type 2 diabetic?
So let me clarify, you mean to say starting with the DPP-4 SGLT2 inhibitor combination right at the beginning? No.
How would you like to go about? I'm not asking you it has to be with this combination. I mean, what would your take be? 1 drug, 2 drug, 3 drug, or 2 drugs or 3 drugs to begin with?
Right. So when we were at Nair, and I don't know what the practice is now, so Sukriti can tell us, it was the traditional give metformin 500 milligram twice a day, wait for 3 months, HbA1c not controlled, you step up the medication. And that was traditionally what I was used to doing when I got into practice. But yes, definitely now my practice has changed a great deal. And now even with patients early in their type 2 diabetes, I do prefer to start with the combination therapy, especially after the verified trial came out. And it gave us good data saying that starting a DPP-4 metformin inhibitor combination right at the beginning, even in patients with HbA1c like 6.57%, give them the advantage of durable glycemic control, and of course the risk of failing therapy is greatly reduced. Having said that, what Sukriti pointed out, I do definitely follow the ADASD guidelines, and if there is somebody who already has an established atherosclerotic cardiovascular disease, already has congestive cardiac failure or chronic kidney disease, then yes, in them I would choose maybe an SGLT2 metformin combination rather than a DPP-4 metformin combination. And the only thing is that DPP-4 metformin, I don't have to think too much. I don't have to worry about calling the patient back in a week, seeing whether they are having any genital problems, any candidiasis. So DPP-4 metformin makes me feel comfortable. I don't worry about the patient. When I initiate SGLT2 metformin, I definitely worry about the patient. I ask for a follow-up within a week, 2 weeks, and I make sure that I follow the patient up more carefully. So one is ease of prescription of DPP-4 metformin probably wins out over SGLT2 metformin. The only other point I wanted to take, so one of the posters I presented at IDF was, I looked at about 500 patients coming into my practice, and the amount of patients who were in that atherosclerotic cardiovascular disease, CCF and CKD group was a very small percentage, about 15 to 18% of my clinic is of that kind of patient. So though the ADASD guidelines put the SGLT2 as the star of the entire algorithm, but in clinical practice, it doesn't really hold true, and maybe it's the flip.
Yeah, so the garden variety type 2 diabetics are not the ones who already have heart disease and progressed into trouble. Yeah, so Tejal, while you are still on this thing, you'll tell us a little about this glycemic variability that we keep hearing, the time in range, and how a DPP-4 inhibitor is a useful tool in these patients.
Sure. So of course, again, when I was training, glycemic variability, CGM, all of this had not yet come in, and there wasn't much information about that. But yes, now of course, also when your patients do more SMBG values or they opt for a CGM, you do get to see more data. So previously, all we were looking is like at one fasting PP. Then it evolved into fasting PP and HbA1c, and that's all we looked at to manage patients. But now I think with the introduction of new technology, we're getting more data, and we're waking up to the fact that there is something like glycemic variability. It needs to be addressed, and it does have an impact on patient outcomes. What I like about DPP-4 inhibitors in terms of glycemic variability is that they kind of smoothen out the glycemic control. So even if I have a patient who's on a basal bolus regimen, but those fluctuations in blood sugars which occur, adding on a DPP-4 inhibitor kind of smooths out the glycemia for our patients, and those big ups and downs are not seen. So yes, of course, in your patients who who are on only oral hypoglycemic agents, it helps. But even in patients who are on insulin, I find the addition of a DPP-4 inhibitor makes the management of the glycemia so much more better. And now that we have targets for time in range, and we need our patients to be in time in range for 70% of the time, so it definitely adds to our armamentarium.
So one provocative question, is there any difference in terms of glycemic variability and the use of a particular DPP-4 inhibitor?
So,
You don't have to be
so
diplomatic, please. You give a straight answer.
yeah, so everybody does come out with their own data, but yeah, if you look in terms of glycemic variability, then I think vildagliptin is one of the best ones in terms of the glycemic variability thing that we have. The twice a day works really well. And I also think that they now have some pharmacokinetic and pharmacodynamic data even for the once a day vildagliptin, which they do say that is almost the same as the twice daily dosing. So and also, of course, the reduction in cost has added a great deal. You feel so much more, I think, less guilty in prescribing a DPP-4 when you know you're not costing your patient that much.
Okay, so we all know that the number one cause of mortality in diabetics is CV disease, cardiovascular disease. And I'm going to request Dr. Dhiren Shah to give us a little brief about the heart in diabetic patients. We are hearing so much about heart failure. I mean, 4-5 years ago, it was myocardial infarction, arrhythmias. Heart failure was not what physicians were so much exposed to. Now, in the last 3-4 years, or to be more precise, after Sevatimi, hospitalization for heart failure has become a very, very big issue and an important parameter. So if you can give us a little brief as physicians, we are not cardiologists.
Yes, you are beyond cardiologists, endocrinologists, getting more broader view on the entire human body. We are looking only centrally. Okay, so what I was to say, that every time we studied our ischemic heart disease, we always thought diabetes is one of the risk factors. We take care of diabetes, then we realize role of HbA1c, fasting PP, and now glycemic variability. And we want 70% time in range blood sugars. But coming to this point, it is not pure ischemic heart disease what we were talking about all these years. There was a little difference even in diabetic patient working on myocardium at a various tissue level, like in diabetic nephropathy. Even creatinine is normal, they still have continuous small amount of microalbuminuria. So some ongoing process. So I think in diabetic being microvascular disease, I think just to prove that point, couple of patients we used to label coronaries are normal, diabetic patient LVA 40%, generalized hypokinesia, angio normal. So this was basically a diabetic microvascular disease, what we used to label as diabetic cardiomyopathy, like that. So basically diabetes does affect coronary artery, does affect interstitium, does affect myocardial metabolism. And in general, after a little more data available on echocardiography with diastolic parameters available in the form of diastolic 1, 2, 3, 4, E upon E prime velocities, better assessment of pulmonary hypertension. Now we realize that heart failure is not only the systolic phenomena and due to myocardial loss in myocardial infarction, but it is also a phenomena occurring in a good number of diabetic patients with a preserved ejection fraction. And probably the mechanism is working via altered interstitium, maybe some growth factor or some effect on microvasculature, giving or cellular energetics, intracellular effect in diabetics. So really we don't know why this EF drop in diabetic cardiomyopathy, what we used to label. And a couple of patients, they have a totally a different, the systolics are grossly affected, diastolic is not as much. I mean, we are still in the understanding phase in each and individual patient to really dissociate ourselves from pure systolic dysfunction, EF20 with grade 1 diastolic dysfunction, and one who has EF of 45 and advanced diastolic dysfunction. So we have not understood diastole so very well. Like we have a figure in EF, 45, 35. In diastolic, grading also does not put you to the right perspective. Patient may not be symptomatic with EF15, with grade 1 diastolic, a person with 45, with 40 meter step, yet grade 1, grade 2 dyspnea. So I think we are in a lot of learning process where probably some role of SGLT is coming in. But it's difficult. Both systolic and diastolic dysfunction both gives rise to heart failure in diabetic patients. Whether
So-
coronary artery disease or via interstitial mechanism.
So my question then is, as a physician, non-cardiologist, and I'm seeing diabetic patients, what is the minimum investigation that I should ask in my patients who's otherwise asymptomatic? I'm not talking of someone who has shortness of breath or who's got something suggestive of an ischemic heart disease. But in a routine follow-up, like we do microalbuminuria, we do lipid profile, we do an HbA1c once a year at least. So is there something that should be carried home by the physicians that you should do 1, 2, 3 at least?
So I'll put it in a little odd perspective. Health checkup we follow for a normal person beyond 45, arbitrary. You know, every 3 years you do it. Maybe after some detection we may do yearly. In diabetic patient, probably in initial years, you may not be very aggressive, but somehow about 20% of diabetic before just on a first year of diagnosis, they face with macrovascular complication. So that is also true, that it is not to be taken lightly. But I would say about anywhere beyond 5 years of diabetes, once in 3 years of a stress test and once in 3 years of echo, alternate. So you can every alternate year do 2D echo like you do peripheral vascular study sometime or ophthalmic evaluation for retinopathy. I would rather say once in 3 years, and you have ASCVD obviously once in a year,
No, then
both by echo and stress test, no doubt. At least stress can be decided, but echo is a must because it gives good idea of systolic, diastolic function and overall heart, function in general.
Okay, so that's great. Sukriti, we've heard so much about heart, so when there's a joke that when these various organ systems of the body started arguing that who's the main boss. So we also understand that kidneys are very important. The kidneys talk to the heart, the kidneys talk to the liver. So in diabetic patients, when there is a declining renal function, we always worry about adjusting the dose of medications. So what is your take on DPP-4 inhibitors? And okay, the next part of the nephro part, I'll ask Tejal because she's the expert on it.
So, sir, that's the beauty of DPP-4 inhibitors, that the dose adjustment which we do for DPP-4 inhibitors is because of their pharmacokinetics, not because of a safety concern. Because the effect which we would get at the max dose, like 100 milligram of sitagliptin or a 50 milligram BD of vildagliptin, would be at half a dose. We would get the same dose in a patient with renal failure. And the second important thing is that mostly we are worried that the drug may cause hypoglycemia because the concentrations may rise. That is another concern which is abated by DPP-4 inhibitors. Because once you give the DPP-4 inhibitors, almost 100% of the enzyme is inhibited. And we know it works through GLP and GIP mechanisms. So it would happen only if the glucose is above the fasting glucose level. So these two effects are beautifully managed by DPP-4 inhibitors. So even if we sometimes do not know, patients do not follow up, even if the creat is rising and the patient is on DPP-4 inhibitor, that will not be as much of concern as with other drugs. Otherwise, linagliptin, which has basically intrahepatic circulation and 6% of renal elimination, does not need any dose adjustment. Rest of the drugs need some dose adjustment after the eGFR falls below 45, but mostly because of the pharmacokinetics.
Great. So Tejal, what Sukriti just said about the dose adjustment. Is it that one DPP-4 inhibitor is very safe? So we are talking of safety, we're not talking of dose adjustment in renal disease versus the other DPP-4 inhibitors. And number two, extension is if we fail to reduce the dose as mentioned in the literature or in the package insert, what are the possible side effects that you would think could happen?
Actually, the second question is very interesting because, all of the time we're told if you don't reduce the dose, but actually if you don't really reduce the dose, nothing much happens. So yes, you can reduce it whenever you come upon the patient and you realize that, okay, now the GFR has fallen. And as she pointed out very well, it's not because of the safety reason that we're concerned about the dose adjustment. So the second question is a very good one that I don't think we need to scare people about the dose adjustment, but yeah, of course, you must make appropriate dose adjustment. And the first question, yes, so the answer to that is, I think all the DPP-4 inhibitors in terms of safety for CKD, I don't think there is any one which is very safe and the others are not so safe. So it's mainly to do with the ease of dosage adjustment, but otherwise safety-wise, there is no difference. In liver disease, yes, there may be, but not in kidney disease for sure.
Okay. So since you mentioned about liver disease, I'll stick to that. But let me ask you if you've had any experience using DPP-4 inhibitors in patients with end-stage renal disease, patients
Yes.
on dialysis, and patients after transplant.
Yes. So all across all these, this entire gamut, and as Sukriti also said, one of that's the best part about a DPP-4 inhibitor, that you don't have to worry. Side effect profile is really good, and yes, I've used it across the board. The only place where maybe I don't find it very useful sometimes is if patient is already taking a lot of medications, the pancreatic beta cell function is almost run out. Then at that time, it may not be very useful. So some people still like to continue to suppress the glucagon. But I feel if the patient is already taking insulin 4 times a day and is stable, there is not much of glycemic variability, it may not add much. But otherwise, across the board, yes.
Perfect. I think when they are already diabetic for last 25 plus years on insulin and multiple drugs, if you can, because these guys end up on so many antihypertensives.
Right.
Probably on our part, we can reduce the anti-diabetics at least.
And at least not a new initiation at that time. So sometimes you see prescriptions when people initiate a DPP for like 20 years of diabetes. That doesn't make sense.
Yeah, it's not a wonder drug that way.
Absolutely.
You mentioned something about liver disease. So let's spend 2 minutes on that also from your side first.
Yeah, so the only thing about liver disease is I'm a little wary, and most of the time in liver disease, I try not to use any oral hypoglycemic agents at all. If at all, I use a short-acting sulfonylurea and probably mainly insulin, because of course we all know that the data is anyway quite limited in liver disease as well. The only thing is that vildagliptin, there's a little bit of red flag with liver disease, but as all of us as treating clinicians, as long as the patient is stable and has not gone on to end-stage liver disease, we probably anyway would just avoid the DPP-4 inhibitors altogether in that situation.
Yeah. Dr. Dhiren Shah, we keep hearing about CV outcome trials ever since that rosiglitazone fiasco in 2008.
Yeah.
And now it's nearly 14, 15 years. And there is a talk that US FDA is saying that do away with these CV outcome trials. So do you think in our setting, general practice that we are doing, the CV outcome trials are very important for us, and the fact that vildagliptin doesn't have a formal CV outcome trial doesn't mean anything much to you?
I don't know, but from 2008 till now, whatever the practice is going on internationally is we are going by CV outcome trials, and that is how SGLT2 has come up so much in the guideline on higher level. And probably there are diabetologists who say it is even above metformin, using first drug. There are a couple of people I've heard that with such a benefit available with SGLT2, why metformin should be still adding anyway. That is point aside. But presently with DPP-4, trials are all neutral. As far as the need of CV outcome trials are concerned, I'm not very sure what to really give answer on, because we have already been benefited by now in 2020, in 11, 12 years of last from 2008. This new molecule, EMPIRE trial, first time came up with this, and suddenly we got this, maybe, and with diastolic dysfunction getting a newer molecule in the market, we are expecting few more new modality drug, not working like SGLT2, working, so there they have to show, outcome trials. for diastolic dysfunction. Otherwise, so I think at some of the molecule you may still need outcome trials, but in diabetics, I don't know.
Yeah, I think I agree that there have been a lot of eye openers. You see, the CV outcome trials were more for safety and not for the efficacy part.
Correct. It turned out to be a benefit at the end, but it was done for safety purpose.
So it was always safety and non-inferiority. No one expected. See,
Absolutely.
when a diabetic patient is on 2 or 3 anti-diabetics, ACE, ARB, statin, aspirin, what additional did you really expect? So this is what has been very exciting with the SGLT2 inhibitors and with the GLP-1 receptor analogs, that they're actually protective. So let's see how things turn out in the near future. And probably what is exciting is a couple of new GLP-1 receptor analogs and some
Oral one
yeah,
particular.
and newer anti-diabetic drugs are also on the horizon. So it's going to really be exciting. But okay, Sukriti, you tell me now. We expect, we hope to live longer. We are actually living longer. Our life expectancy has gone up by about 18 years since independence. So what is your take on using DPP-4 inhibitors in the elderly? So, let's be more precise, in the very elderly, 75 plus, because now 60 is still young and 65 is middle age.
Right, sir. So that is the forte of actually DPP-4 inhibitors to be used in elderly population because of excellent availability, oral bioavailability. Injectables are a bit difficult in elderly population, and we do not need the strict 7% ADA prescribed HbA1c in them. So even a drug which provides not very high intensity reduction, but an intermediate reduction is good enough for us. And when people are on polypharmacy in the old age, the drug which is preferable is which has minimum interaction, minimum side effects, and is can be orally taken. So there DPP-4 takes the crown to be used in elderly population, where our main focus is to reduce hypoglycemia rather than to have a very strict diabetic control.
I have a small query. When you are saying elderly, if it's a long-standing elderly diabetic, the efficacy will be less in this group also. It is very safe, we know, and this is the right drug of choice in elderly, so that hypo is avoided. But efficacy-wise, it may be little less in being a chronic, long-standing diabetes.
Sir, even study-wise, they did a research in people who are elderly population with vildagliptin only in people who are more than 75 years old. So as compared to other anti-diabetics, those side effects were even less. The efficacy was comparable to SUs. So we reduce the side effects and we maintain a comparable efficacy. Excellent. And the most important thing with DPP-4 inhibitors is a drug is as effective if the people are tolerating and taking that. We could prescribe any medication and we would expect a brilliant result. But if the patients due to side effect profile are not adherent to that, that would make maybe of less use to us. So their DPP-4 inhibitors are better due to their better side effect profile, less interaction.
Very
good. So Tejal, while we are on this topic of the elderly population, so if you were to get not 25 years of diabetes, but someone is say 10, 12 years old and 75 plus, how comfortable would you be, and what does the literature say about prescribing SGLT2 inhibitors?
So I'm not even going to talk about literature, but I don't want to start it in elderly 75-year-old, very honestly. So yes, I know that the clinical trials did have elderly patients and all, but I think more than the age, I think it's the frailty of the patient that you look at. So when you have a frail elderly patient, I know that it may reduce the risk of MACE and CV mortality, but I'm so worried about them getting a urinary tract infection, landing up in the hospital, electrolytemia, confusion, and the typical, neurological deterioration that even the mildest infection can set off in an elderly patient. So I would be extremely wary of using SGLT2 inhibitors in very elderly patients.
Good.
To chime in, sir, as ma'am said, we have been recently seeing SGLT2 inhibitor euglycemic decay in elderly population right now. We saw a few patients who were admitted with that, and elderly people succumbed to actually that, rather young people recovered. So we are presently very wary at using SGLT2 inhibitor in the elderly population.
So Dr. Dhiren, I wanted to hear from you your experience, in the elderly population, patients who are on antihypertensives, specifically on a diuretic, and you need to actually modify the prevailing oral anti-diabetic treatment, then what would your choice be, and what is your take on using SGLT2 inhibitors in the very elderly?
As far as possible, I think frailty index, people who are very frail, we are little scared to use. And even when we use, we are little worried. We are not comfortable. While writing DPP4 here will be somebody is already on DPP4 well controlled or the poorly controlled, and I need to add something. I'll be little hesitant to start SGLT2 beyond 70. Beyond 70, I would be hesitant to start unless there is an indication like additional heart failure already. And now the dapagliflozin and other gliflozins are being recommended strongly as much. So, but very rarely I think of adding SGLT2 at that stage. If patient is already on sulfonylurea small dose, metformin little, and on top DPP4, sugar getting out of control, I'll be little skeptical using SGLT2 at this point. Maybe small dose of basal insulin or something. I don't know, it is your territory, whether what to take it from there. But I will be happy with adding small dose of basal or something and keep him little less hypoglycemic, not to give bolus dose at all, because I'll be worried of hypo.
Great. So I think in the last about 35-40 minutes, we've gone through the ADA ASD guidelines. We have looked at the glycemic variability and how we can try to reduce the glycemic variability primarily instead of focusing only on the A1C. The cardiac safety of DPP4 inhibitors, the safety in patients with declining renal function, and even in patients with end-stage renal disease and dialysis. A little caution, especially with severe hepatic dysfunction. With mild, moderate, we can use most of these drugs, and the use in elderly population. So it all in all seems to be well placed to be used in type 2 diabetics. So I'm going to ask each one of you to give a just take home message on today. If you were to look at the position of DPP4 inhibitors, how would you put it down on paper, or what is your 2 or 3 point take home message? So Tejal, you want to go first?
Sure, sir. So, maybe we have now, we are now at a time where most of the time we'd start a DPP4 metformin combination right at the start of diagnosis of diabetes when we decide to start treatment. If GI tolerability of the medication is good, then there's nothing else we really need to worry about in this patient. Dose adjustment, no dose adjustment, everything. Glycemic variability, even as add-on to maybe insulin therapy, earlier in diabetes, maybe 8 years, 10 years, it may help improve the time in range. And not only regarding DPP4, but overall, I think that all of us, we need to individualize patient treatment, look at the individual patient, look at the patient as a whole, take everything into account, and then select what is the right drug for the patient.
Sukriti, your take. You're going to start practice soon, so
yeah. So exactly as ma'am pointed out, DPP4 for me is a very safe drug. Like even in Nair, we have started prescribing, that's available with us in our pharmacy. So we have started prescribing and it shows brilliant results. Though in studies, I know 0.8 to 1% reduction, but we have seen brilliant results with the gliptins. And the second thing is the safety and the less amount of interaction with the other drugs. There's safety in renal failure. So all in all, a good drug. But probably not to be started in people who have been diabetics for a long term. We may not reap that much amount of benefit.
Absolutely. So yeah, it has its own benefits. But remember that every anti-diabetic, or for that matter, even antihypertensives, you may find a set of patients who don't respond to the drug. So they may be unresponsive. So within, say, a fortnight or 3 weeks, whenever you call them up for follow-up and you don't see the desired results, please don't hesitate in going on to the next class. Maybe this is that odd patient who's not responding to your DPP4 inhibitors.
Right, sir.
I just got this thought before I go to Dr. Dhiren Shah for the last remark. See, when I was a student, couple of decades ago, not years ago, we were taught that type 2 diabetes, fasting on treatment going above 250, A1C remaining above 9, patient losing weight, not getting controlled. I'm not talking of infection, pregnancy, surgery, just a routine type 2 diabetic. You need to put this patient on insulin. And after DPP-4 inhibitors came in, and now with the SGLT2 inhibitors, this teaching probably has to change. Because, yeah, there are so many patients that you've seen, maybe anecdotal, but the fact is that until the patient you feel is in a catabolic state or is really symptomatic, you can do with oral anti-diabetics. So that has made a real big difference in management of type 2 diabetes. So Dr. Divya, probably you're going to be the last speaker for the day.
Yeah.
Summarize what is your take as a cardiologist. So, before you start, let me tell you something about cardiologists and endocrinologists. So the cardiologist always says that diabetologists don't know how to manage their diabetes. And that is why they end up with so many cardiac patients. And my professor always used to say that cardiology is nothing but secondary hyperaldosteronism. So if you can control that secondary hyperaldosteronism, there won't be much work left for cardiologists. But anyway, that's in the lighter vein. You could sort of give us your last word on this.
Yeah, correctly. I think I will put my remark in a little odd way. Your remarks were well taken, no doubt. But the thing is, DPP-4 inhibitor, if we try to compare, just try and see how a general practitioner would to treat any breathlessness. Give Derifile. Just you see time and again, wherever some breathlessness, whatever, the doctors come and give in Derifile. If you go to a GP for a hypertension, a smart young GP would amlodipine, just don't bother. You just don't have to worry on any side effect. Edema may come, BP 170-100, night no cough, no other issue, no. So similarly, we have got a molecule which works on so many, octet, entire thing it works. And I think octet is going to change to now 10 or 11. They're finding out new other sites where the diabetes is likely to be a culprit, at the end result of those things. So at that point, I think DPP-4 is going to stay. It is working at multiple sites, very well tolerated, going in elderly, going in end-stage renal. And I'm putting myself as a general practitioner, not endocrinologist. But if I am a general practitioner practicing, I will say DPP-4 is my drug of choice, comparing all other anti-diabetic molecules. Can be prescribed very, very safely with a standard metformin. Not anybody would argue with me.
Okay, I think that sort of puts everything into a nutshell. We have understood its position. Unfortunately, there isn't a provision for taking any questions from the audience. So if any one of you, either three of you want to ask each other any question, please go ahead. We still have 2-3 minutes.
Yeah, 1 or 2 questions if I can be permitted.
Yes, Tejal and Sukriti are there. They will answer.
I'm asking to you. Asking to you. That is why I asked permission. So, do you think this 6 to 6.5 HbA1c people on regular follow-ups without diabetes? I'm saying it's a sort of borderline 5.7 to 6. So, do we think such patient we can be putting on them on a treatment with metformin or DPP-4 in all these patients? The scope will widen. I don't know, only few may end up in diabetes, say 20-30% at the end of the day. 80-70 may remain in the same range, I don't know. But do you think that we should be treating them with any values to delay the onset or avoid diabetes?
So you are talking of that set of patients who are called pre-diabetics, 5.7 to 6.3.
Correct. And follow-up, say 3 years follow-up. All the time they are coming in a similar range, routine health checkup, they come in. We say you do, lifestyle modification, dietary. But is there any role of, drug to delay the onset of diabetes?
I think what I would go first, and then I'll let Tejal and Sukriti also give their remarks, that if after 4 to 6 months, we have not got them into the so-called normal range, then there is a definite place for using one of the drugs that you mentioned, either metformin or DPP-4 inhibitor. And today there is so much pressure from all over for using SGLT2 inhibitors. You're hearing about SGLT2 inhibitors in non-diabetics also. I'm not going to that extent, but when these pre-diabetic patients, mild increase in BMI, doing all the right things, and the A1Cs are 6.5 or so, it does make sense to make them on a small dose of metformin. Or
You do recommend, yeah. That is very, very important.
More than the A1C, the idea is to tell them that you have a problem. Please don't take it easy.
Correct.
Yeah,
Maybe that in a background of strong family history or something, we would be more aggressive.
Yeah,
heart disease. Couple of other clues, whether he's a smoker or some other clues, then we'll be little more aggressive in that particular gentleman.
Absolutely. Then your threshold becomes even still lower.
Lower. Yeah, that's right.
And just one hidden epidemic, which is going to be liver disease. That's going to be like the most, I think it's going to even overtake chronic kidney disease in the future, maybe 15, 20 years down the line. So diabetes patients, there's an epidemic of NASH, NAFLD, and ultimately liver failure. So that's also one of the things where starting even maybe a saroglitazar early in that for that small HbA1c reduction and prevention of progression of liver disease also what I think this is something that we have to keep in mind for the future.
Absolutely, Tejal. We talk of fatty liver progressing to NAFLD and NASH, and then cirrhosis and hepatocellular carcinoma. When we were learning, we were talking of a 2% risk of progression from fatty liver to cirrhosis. But 2% in our population of diabetics is huge. See, if you look at the absolute numbers, it's huge.
Huge.
So I don't want to get COVID into the discussion, but we are looking at 2% mortality in COVID and see what is happening to the world. So if you're talking about 2% progression to cirrhosis and maybe a smaller progression to hepatocellular carcinoma, you're looking at a huge number. Yes,
but is that any clarity that it is all these 2% are the ones who all are poorly controlled or something, or badly managed or what, or it is to anybody? A fairly controlled diabetic will go into say, I'm talking about in general, like the coronary artery disease, we know poorly controlled, and yes, there is a correlation. We do find those people. Cirrhosis also, is it that?
So the thing is, when you're talking of fatty liver or NAFLD, most of it is reversible. Like I said, 95-98% is reversible. But yes, initially it was diet control, lifestyle modification, weight. Now we're looking at certain drugs. And in the near future, you're going to have specific anti-fibrotic drugs. But somewhere we may still have a occasional case who says, I've done everything good in life and still why I've got in trouble. We don't have an answer. But yeah, large majority, the answer is what you are saying.
Correct. Very nice to learn from 3 leading endocrinologists or a cardiologist. Really, it was worth it.
No, sir. It's always you see, now there is so much of interaction amongst different specialities. Yeah. We must make use of that.
Yeah. And to be honest, my practice is going to be endocrinology is more likely to be, because I see so many if I don't know my diabetes well, I can't practice cardiology. So it has come to that stage.
Yeah, Eugene Braunwald a couple of years ago had coined this word cardiodiabetology or diabetocardiology, whichever way you want to say it. And they're actually talking of starting fellowships in the US on diabetocardiology.
That's worth it. Yeah, worth it.
Okay, Sukriti, any last word before we call Mandar in, or you're done?
No, sir.
You're done. Okay.
Yes.
Great. So on my behalf, thank you very much, Tejal, Dr. Dhiren Shah, and Sukriti. And I hand
you Dr. Chadha.
Sir, if you permit me, I would like to ask one question to the panelists, if you permit.
Please go ahead.
This is very contemporary, and I'm not asking this because Alkem has launched Gluvilda OD100. And in fact, Dr. Tejal Lathia spoke about it. But I just would like to know the panel's opinion, because it is when we are promoting 100 milligrams of vildagliptin sustained release, we are getting a mixed kind of a response from the physicians, endocrinologists, and cardiologists, and of course, even some of the general practitioners. So I know Dr. Chadda's opinion about it because I have interacted with him regarding that. But I would like to know the endocrinologists and, of course, Dr. Dhiren Shah's opinion about this sustained release vildagliptin, which has come recently in the last 3 months, because it has got to do with the pharmacokinetics and pharmacodynamics of the drug. And we rarely discuss the pharmacokinetics and pharmacodynamics of these molecules. So in the history also, I mean, all of you know better than me that such kind of drugs have come. For example, glycolazide became.
So we've lost Mandar. Tejal, you want to go first on your opinion?
Oh, so it's a difficult one. The data is limited.
Clotrimazidine
Yeah, sorry,
became,
go ahead.
Modified release. So I just would like to know from all of you, where does vildagliptin sustained release 100 milligrams stand today?
Sorry, so Mandar, we were in the process of answering your question. So there is limited data which says that the 50 milligram twice a day is as good as the 100 milligram once a day, and that is why the DCGI did approve it. So I think from the compliance perspective, I would be happy to have a single tablet and I can give the patient once a day and be done with it. And especially with the vildagliptin metformin combination and somebody whose fasting blood sugar is not very high, then I would be very happy to give it once a day for a patient. And I think mainly from the adherence and compliance perspective, I would be very happy.
Dr. Sukirti, your take.
Yeah, so the basic difference between vildagliptin and other gliptins was their mechanism of action. They all have been grouped under the DPP-4, but they are all different molecules actually. So vildagliptin bounds covalently with the DPP-4 substrate, whereas other do so non-covalently. Vildagliptin, the original molecule, had a very short half-life of 2.5 hours only. It could work for a longer half day, like we could give it twice because of that covalent interaction. So if we are having a drug which is sustained release, we could it is equivalent to a drug which is longer acting. And efficacy wise, we've seen a comparison between sitagliptin 100 OD and vildagliptin 50 BD. So vildagliptin did better in terms of that. So yes, sustained release, if it is equivalent to the vildagliptin 50 combination in the normal molecule, then yes, I would definitely prefer it because of the, as ma'am pointed out, a single pill a day improves compliance.
Sir, your opinion.
Yes, I would say I'm forced to use once a day because by the time any cardiology patient, his prescription will have 4, 5, 6 drugs, statin, aspirin, clopidogrel, some, trimetazidine here and there, nitrates. So I want once a day, and there are already once a day preparation available in the market. So in any case, if I have to add vilda, that inhibition of twice a day is now gone. And I don't think I'm having a choice but to use anything once a day. So I would opt for scientifically the other 2 persons they've said, but I will be forced to use once a day vildagliptin if given a choice.
Last word from the moderator.
No, so the thing is, historically, vildagliptin was like the other gliptins. Trial drug was 100 milligram once a day. And the original studies were with 100 milligram once a day versus 50 milligram twice a day. And what they found out, the reason why 100 milligram was not developed was that the risk of liver dysfunction and QTC prolongation were more with the 100 milligram dose versus the 50 milligram twice a day. So that's why 100 milligram was never developed internationally. Now we have multiple brands available in our country, 100 milligram twice a day. And I keep telling these people, I'm not asking for efficacy. I'm not asking for pharmacokinetics. I believe it that 100 milligram OD sustained release works for the full 24 hours. My question is again the safety part. Has anyone ever looked at it? And I doubt anyone will be able to give me this answer because no one is going to do a study on this. We have learned to prescribe teneligliptin left, right, and center. I think we'll learn to live with vildagliptin OD also.
Yeah, but that first reference you made, that 100 milligram once a day was a sustained release at that point?
No, that
and
was
this is sustained release. So this is a little different modified release technology. So maybe there may be a difference there. Maybe I'm just
no. So unless yeah, someone does a phase 4 post-marketing study, you'll never have an
Yes.
answer to this question.
Correct. Unless the documentation is done, you can't have an answer. Very right.
So Mandar, we are done.
So we are bang on 8:30, sir. As I said, we would finish in 1 hour, and the entire credit goes
Mandar
to
was
all.
good enough to take last 5 minutes to prolong this. Okay.
So it was a fantastic discussion. I don't think we could have asked for anything better than this. So as a Alkem, the 5th largest pharmaceutical company in India, I thank our esteemed panelists, Dr. Tejal Lathia, Dr. Dhiren Shah, and Dr. Sukirti Mishra for having joined with us for today's evening's discussion on DPP-4 in the present era. It was really a very, very enlightening discussion, and I'm sure the audience definitely would have benefited from this. I also would like to thank our moderator, Dr. Manoj Chadda. It was beautifully moderated discussion today. We are, I think we are at the end of the second wave of COVID, but then all of you definitely are also seeing the patients physically as well as online. I would just like to inform you before we close the session today that Alkem has got one platform called as Connect to Clinic, and I'm sure our field force will come to you for briefing on Connect to Clinic, which is a online platform that we have developed on our own. So for this moment, I say goodbye to all of you and good night. Thank you, everybody.
Thank you, Dr. Chadda. It was nice.
Good night.
Thank you, ma'am.
Good night. Good night. Bye, Dr. Srikati and
Good
Dr.
night, everyone.
Bye.